Well, hello everybody and welcome to another episode of GUcast. This is Declan Murphy, urologist at Peter MacCallum Cancer Centre, joined as ever by my co-host, Dr. Renu Eapen. Hi, Renu.
Hello, good to be back.
We're not at Peter Mac today, are we?
No, we are offside again, but it's an exciting time. I mean, not only are face-to-face conferences back, but it's time for visiting professors.
Visiting professors are back. And, you know, when we started this podcast way back in early 2020, which was pre-pandemic, all the planning, one of the reasons we wanted to do it is in Melbourne, Sydney, we would often get fantastic visiting professors traveling through. They might stop in and do a dinner meeting to talk about an area of GU oncology, and then next day come and visit places like Peter Mac and Monash, Eastern Health, the Austin, all these big centres. And visiting professors were a real highlight, I think, way down here in distant Australia. We loved having visiting professors, and of course, none for 2.5 years.
Yeah. Do you remember that photo of Monty Powell with his sunglasses on at Peter Mac?
That's right.
It was he
was almost the last one.
I think so. And
but
the pandemic
thankfully, life is straggling back towards normal, and we have a visiting professor in town tonight here in Melbourne, and we'll get to our guest in a second. But yes, we're not in our normal location because we've relocated down to the Park Hyatt, which is a very nice hotel in city centre Melbourne, a great place for these types of visiting professor or medical education evenings. And next door, they're setting up a big room where we're going to have visiting professors doing a talk later on, and we'll have people streaming out and in from around the country to make the most of that. So it's great to have these events back, and we've celebrated by moving all our kit down here to the Park Hyatt.
Not a bad room, actually.
No, not a bad room.
Nice.
And also, this is the first of our themed podcasts. So we mentioned in our recent short podcast that we've opened a partnership program to allow our friends in industry to support the podcast, because they've been saying how much they enjoy it, and it's a good way of communicating medical updates in GU oncology, and industry have been very kind to say, how can we help? So we the kit is all expensive, production's expensive, we've done it all for free with the support of one of our charities, but we're delighted that among our partners, who you can read about on our website, gucast.org, we have Janssen as one of our key gold sponsors, and part of our program with Janssen as a partner is that we do some themed podcasts. So disease areas of mutual interest to industry and also to us and to our listeners and viewers will be focused on. And this is the first of our themed podcasts supported by Janssen. And tonight we're focusing on metastatic
Hormone-sensitive prostate cancer.
Exactly. Very important topic. Important for us urologists, but also for radiation oncologists, medical oncologists, patients, of course, and industry who all listen to this podcast. And it's been an area of a lot of progress over the past 6 or 7 years. And Janssen have one of the drugs that have been very exciting coming into phase 3 trials in this area, apalutamide. So we will talk about that, but we'll talk about everything else to do with metastatic hormone-sensitive prostate cancer as well.
Yeah, it's going to be really interesting, because I think it's one of those areas that hadn't changed for decades. You know, it was always ADT for decades and decades, and now there's been lots of changes. So it's an exciting time.
Exactly. So for us as urologists, I think of all the stakeholders in metastatic hormone-sensitive prostate cancer, I think we need to really redouble our efforts to educate ourselves on the rapidly changing options in this space. So with that said, shall we introduce our guests on the podcast?
I think we should.
Yeah, fantastic. So it's a great pleasure to welcome back to the podcast Dr. Ciara Conduit, medical oncologist at Peter Mac in Melbourne. Ciara, thanks for coming back.
Thanks so much for having me.
So good to see you, Ciara.
It's been
Thanks.
Looking forward to it.
Ciara, you're a medical oncologist specialising in GU oncology, so this topic area is right up your street.
Yeah, definitely my pet topic.
Fantastic. And sitting beside you is our visiting professor in Melbourne this week. It's Professor Fred Saad, the Chair and Professor of Urology at the University Hospital in Montreal. Fred, welcome back to Melbourne. Great to see a visitor.
It's great to see you in 3 dimensions, Declan.
Exactly. It's been like that for the past couple of years. We do still see you and hear you likewise, but it's so much better when we have a visitor in town.
Absolutely.
And thank you for coming all the way down. And we love having you in town. You've been a key opinion leader in prostate cancer as a urologist for decades now, really. And I think you've always been one of my heroes in prostate cancer, because you've really embraced not just the sort of prostate cancer urologists deal with, localized mostly, but you've always been interested in systemic therapies for prostate cancer and for support of prostate cancer patients. So welcome back, and great to see you.
Great to be here.
Yeah, a true surgeon scientist, a true surgeon researcher, which is really inspiring.
Yeah, and you're in town tonight on the Janssen tour to talk about non-metastatic CRPC. But what we want to talk about on this podcast is a different area, taking us back a step to these newly diagnosed metastatic hormone-sensitive prostate cancer patients. And I suppose we should start by just saying, the early days of practice for you as a urologist, looking after these newly diagnosed men coming in with high PSAs and positive bone scans and all that. Tell us a bit about that era, about what it was like managing those patients at the start.
Well, looking around the table, I think I'm the oldest person here. So, I mean, I lived with ADT alone, and in an era where when I trained, it wasn't enough to give ADT for a patient who was metastatic. You had to wait till they were symptomatic to say, let's give ADT because of all the side effects. And, is it really worth treating earlier? And it took a long time for us to realize that early intervention makes a big difference in terms of delaying metastases, delaying progression of the disease. And it's been great seeing the state go from ADT alone, castration alone, and then watching patients die with nothing else to offer, to everything that has come along from castration-resistant prostate cancer. And now, as you say, metastatic hormone-sensitive disease is where we have the biggest opportunity to make a huge difference in patients' lives.
And that's meant embracing multidisciplinary work with our medical oncology colleagues as well, Ciara. So can I ask you, is she the youngest in the room? Probably, yes. Yes.
It's okay.
I look nervously around the thing thinking, all right, who have I offended most?
I was actually thinking it's so unusual that we're talking about metastatic hormone-sensitive prostate cancer and she's the only medical oncologist.
I know, but that's why it's so important that we have this audience here because, Ciara, your journey in metastatic hormone-sensitive prostate cancer is really when these combination approaches started. Is it fair to say, remembering back to, I suppose, Charted 7 years ago, can you tell us about your memories of the early days of metastatic hormone-sensitive prostate cancer?
I can. So I actually started in medical oncology in 2018.
Wow.
By which time we already had docetaxel in first-line setting. And the emergence of certainly evidence for use of some of the androgen receptor pathway inhibitors in first line as well. Not that we've had access, obviously. So I think my experience is probably very different.
The total opposite, yeah.
Very, very, very different to what we've just heard. So it's really interesting to hear that perspective.
Yeah, so Renu, that's what we want to do is straddle that. And we want the audience to really get interested in this topic because, urologists, Fred, have been the guardians, the gatekeepers. We've looked after these metastatic hormone-sensitive men, but it's been always with disappointing outcomes. Certainly, I suppose we'll talk about the difference between those newly presenting, those de novo patients versus relapsing. But if we think about the de novo patients, inevitably within a couple of years, the PSA was rising again. Yes, we chuck in some bicalutamide or whatever we have available. All sorts of stuff has come and gone as they got more symptomatic, strontium, etc. But that journey was terrible, wasn't it? The progression to metastases and death was typically, to death rather, was 3-4 years maximum.
And when you think about it, you look at some of the data from Stampede, where they really have the most contemporary patients treated with ADT alone as a control arm in the Stampede trials, and you realize patients become castration resistant in less than a year. When you take an all-comer population. When you take a high-risk population, it's actually within 7 months. And this is a recurring theme. We get the impression that it takes 18, 24, 36 months for castration resistance, but it's actually less than a year. And even in an era where we have a lot of really good options for castration-resistant disease, when you wait for them to be castration-resistant, survival is only 3.5, 4 years. So we really haven't made a big difference if you treat only at castration-resistant state. Really, the opportunity is in the hormone-sensitive state to make a big difference. Starting a year earlier makes a huge amount of difference, and it isn't only limited to the high-volume patient. That's what we've realized, and that's been outstanding.
Yeah, and that's been the evolution of the data in the past few years. But I remember Charted when it read out in 2015, and it did feel like a very big moment when Chris Sweeney stood up at ASCO and read out the results of the Charted study. So just reminding ourselves, Ciara, maybe you'll remind us a little bit, what was Charted? But it's exactly this patient population that we're talking about.
Yeah, that's right. So Charted was a study essentially evaluating the addition of docetaxel to standard of care androgen deprivation therapy. They took a population of patients with recently diagnosed metastatic hormone-sensitive prostate cancer and included patients with both high-volume disease and low-volume disease in their population.
And they concluded that the real benefit was in those patients with high volume disease with 4 or more metastases, and they had a significant overall survival benefit. I think a 30% reduction in risk of death or something like. So it did feel like a very big moment. Let's just add in something that's cheap as chips, docetaxel, and it'll lead to a survival benefit. And certainly here in Australia, by the time you started practice, we were using docetaxel like the following week, I think, after Charted. Was it similar in Canada, Fred?
Absolutely. I mean, that was mind-boggling. Because in metastatic disease, to end up with over an extra year of improving overall survival was unheard of in solid tumors. I mean, this was groundbreaking, and unfortunately it was only limited to the patients who had high volume disease. But we already had an idea that hormonally based therapies would be as effective, but in both groups, because when we looked at metastatic CRPC, the earlier you started, the more benefit you were getting. And that was data that I was involved in with 302, with abiraterone, and with Prevail. If you started earlier, you had even a bigger impact than starting late in mCRPC. So there was already some idea that a hormonally based approach would make sense, but we needed to prove it in clinical trials.
And so the leap to coming forward, this big step again into the hormone-sensitive setting was very obvious to trialists like yourself to make that step, wasn't it?
Absolutely. I mean, we went from post-chemo, hormonally based therapies like ABI and ENZA, and then pre-chemo with ABI and ENZA proving that it's even better. And then the next logical step was both in the M0 CRPC state, but importantly, the larger population of the metastatic hormone-sensitive state that really made a big difference in patients' lives.
And I guess for those who are wondering what really are the options in metastatic hormone-sensitive prostate cancer, I mean, there's probably 4 drugs that have been kind of studied at length. You know, it's docetaxel is the first one, and then there's the abiraterone, which is usually given with a small dose of prednisolone, and then there's the 2 second generation anti-androgens, which are enzalutamide and now apalutamide.
And I suppose darolutamide we can come on to in the triplet
That's
setting,
right.
but so suddenly 3-4 year period that recent years, all these drugs in big phase 3 trials, all showing an OS. So the key message, would it be fair to summarize, is any sort of combination approach up front of let's not just start the ADT and see you in 3 months, but add in docetaxel or these well-tolerated drugs like apalutamide, abiraterone, enzalutamide, and we can talk about darolutamide as well in a slightly different setting. That's the message, isn't it?
Yeah, and it's the onus is on urology. As you said, they're the gatekeepers. And now it's gotten to be, this is strong, but it's unethical that a patient be on ADT alone anymore in 2022. If somebody's on ADT alone for metastatic disease, you have to explain to me why. It's not why should I add something, it's should I not add something.
Why are you holding it
You
back?
have to justify why you're not doing, with all this very powerful data and the argument that it's only a few sites of metastases. In fact, when you look at the subgroups of all of these studies, they seem to be the ones getting the most amount of benefit, and it makes sense. It's a volume thing. The higher the volume, the more likely you have clones that are hormone insensitive, and you're going to get benefit. But the biggest bang is going to be in the patients that you can treat earlier.
So, I mean, we're talking a lot now about double therapy, triplet therapy, and the motto really seems to be hit it early and hit it hard. So, Fred, if we're putting all these drugs into effect earlier in the disease spectrum, do we run out of options when patients turn to castration-resistant prostate cancer?
So what? I mean, the fact is they do better. They stay out of castration-resistant setting, which is the only lethal state of prostate cancer. When you think about it, you don't die from prostate cancer as long as you're metastatic CRPC. And so if we can keep patients out of that lethal state for as long as possible, we're making a big impact. And all the studies are shown an overall survival advantage. So the argument that if you hit them too hard up front, you won't have anything later is a non-argument, because patients are living longer. And it's up to us as researchers to say, well, what do we do next if we hit them that hard early on? And there are good drugs. We've got other chemotherapies. We've got lutetium that's doing extraordinary in patients that have been exposed to both a hormone therapy, a novel hormonal therapy, plus docetaxel. So the fact that we don't hit them the way we should is really not a good argument for the patients.
And the earlier, I guess, we can delay their progression, the longer that lasts.
Absolutely.
Yeah.
And everything, and it makes sense. It makes biological sense that if you hit them early when almost all the clones are hormone sensitive, that they're going to stay in a castration sensitive state for a lot longer.
Yeah, I might just add there as well. I mean, I agree completely with you. And we know from sort of real world data that not all patients get to those 3rd, 4th line therapies. So, the prevailing mentality, not just in prostate cancer, but along, amongst oncology generally, is give your best drugs first, because we know that these patients are going to have longer survival. We've also got supportive quality of life data now as well in many of these studies. And so I think, giving the best stuff up front if we're able to really should be the approach.
Absolutely.
Now that's really clear. These are really clear messages. Fred Saad just told us, Renew, that it's unethical to start your newly diagnosed metastatic patient, unless you need to explain. And there are some circumstances where you can explain it, but he's giving a clear message. It's unethical. We shouldn't think about, okay, what about the next stage and the next stage? So very clear messaging. But as Ciara just pointed out, there is a really big problem with real-world utilization. Now, this is, I think, one of the most important topics facing urologists, I would say to you in particular, as the people who tend to diagnose these people, is we are not doing what Fred Saad and Ciara are telling us. Yeah. We're not doing what the guidelines are telling us and the APCCC are telling us. Because, and we've just published a piece in Nature Reviews Urology where we look at this topic of low real-world utilization rates of combination approaches. And whilst one can say, well, not all of these therapies are reimbursed or approved in all areas, and docetaxel is, and increasingly AR pathway inhibitors are. So we can't just duck behind they're not all available, because all of the drugs have an effect. So I think, what's your comment on that, Ciara? And for example, in this Nature Reviews Urology piece, we reviewed Canadian data, Scottish data, Australian data, Aruna Zad published from here, showing like it's about 25%, give or take. About 25% of people that you might consider might be appropriate around the world get combination approaches. So there's a problem.
Yeah, I mean, I agree, and it's probably far more complex than we could cover in this session here. But, in Australia, I think one of the major issues is going to be funding. Of course, there's probably disparities in geographic areas and perhaps, making sure that everyone's, up to date with the latest evidence. But I think for Australian physicians who are treating patients with prostate cancer, funding has to be the major issue. If we have a patient with high volume disease come to our clinic, offering and recommending docetaxel is easy. But for the low volume patient, to ask them to spend money out of their own pocket to pay for an additional drug over and above ADT is a difficult conversation, and one that we grapple with all the time, let alone talking about triple therapies that I'm sure we'll come to shortly.
Well, there you go, Fred. That's it. But you give docetaxel yourself, I think, in your department. Yeah. You always have for years and years. But so how do we respond to that comment then? Because I think Ciara's right, with the low volume patient, maybe it's more difficult for us clinically to justify it, but I don't think we can duck behind that. If Nick James, if the Stampede team were here, they would say, no, we should give docetaxel across the board. And certainly I think your strong message you gave us earlier has to still be there, even if it's low volume, but it's metastatic and the patient's got a in good nick. Even if we can't access an AR pathway inhibitor, we should at least have that conversation or refer to our colleagues to have that conversation about the value of docetaxel. Is that what you do?
Well, but that becomes a little bit more difficult. For a low volume patient that's 75, 80 years old, giving them docetaxel on top of ADT is not such an easy. And when I'm talking about unethical, it's based on the 4 drugs that have shown survival advantages. And for many patients that have low volume disease or asynchronous disease, especially low volume, then there's a strong argument for an AR pathway inhibitor and less of an argument for chemotherapy. And I agree with Chris Parker and Nick James that docetaxel looked like it was beneficial across the board, but a lot of the data doesn't really support that. So we are using AR pathway inhibitors for patients across the board, but especially for the ones that are not high volume patients. That's for us to lobby for our patients, and I find it outstanding or disappointing or depressing that you don't have access to that in Australia, because, that is probably one of the reasons why there's so little additional treatment than ADT alone if it's only chemotherapy that you have.
Yeah, absolutely. And I find increasingly with this, panoply of evidence that's developed recently, that patients are coming to my clinic, maybe they're doing really well on ADT after a year or two, but in your heart of hearts that if you'd met them that day, that you would have made a different recommendation. And it's a tricky thing to manage.
But ADT is our enemy. ADT does a good job up front, and so urologists get reassured. It plummets ADT.
PSA goes down.
That's why add something that's expensive? Why add a burden of treatment to patients? It actually plays against all that we know. And it's not enough for PSA to go down, because it'll go right back up. Even when it goes down to undetectable. What you want is to keep it that way for as long as possible. And that actually plays against us. And some people don't feel a sense of urgency when patients feel well, PSA plummets, and you just say, well, I'm great. I don't need to do anything more. And that's unfortunately the wrong message to send to the patient and to ourselves.
So Renu, I think thinking as urologists, because I think whilst we've made some arguments there about patient selection and trying to docetaxel, I think go back a step. There is a problem out there that many of us urologists out there either A, are not fully aware of the potential benefit of a combination approach. And let's presume that we only have docetaxel funded. So you're out in country Australia or many other countries around the world listening to this podcast, don't have access to AR pathway inhibitors. That's changing, of course, quickly. But still, I think we urologists have a problem with not talking to the patients, not referring on to medical oncologists for a more informed conversation. Because I think us urologists, me too, in the past, have kind of looked at that older gent to say, I don't think you'll be fit for docetaxel. Yeah. I don't want to send you to the medical oncologist because you know what, they're going to try and give you chemotherapy, and that's about. And then and I remember actually, Fred, back in the days when to get access to AR pathway inhibitors, you had to have had chemo in the CRPC setting, or at least tried it. And that was almost the only reason I would send the odd patient on, saying, I'll just give you, dear Ciara, please kindly give this patient a whiff of docetaxel so he can actually get access to the enzalutamide. And then guess what? You get a letter back 4 months later saying he's now had 10 cycles of docetaxel. He's doing absolutely fantastic, blah, blah. So I don't think I'm the best person to assess. Yeah. So I think for people out there listening, wondering, well, I don't know. Should I be sending all these newly diagnosed patients on? I think we should. We lose nothing. If you're not going to be the person who's going to initiate a drug yourself, then please refer on so someone else can give that patient the benefit. That's I think what the audience should hear.
Yeah, I think it's a real problem, and it's a shame because like we've said now, urologists are the gatekeepers of many of these patients, and it takes awareness of the data and a real kind of a desire to act according to the latest evidence. And I think it takes people like Fred saying it's unethical to keep these patients on solo ADT. For people to realize, actually, well, there needs to be more treatment here. And also, I think now it's such an exciting field. It's not just docetaxel. Now we've got the AR pathway inhibitors, and that now brings it back into the realm of the urologist to treat these patients.
It's our waiting room.
Absolutely. And you don't necessarily, we work as a team in our place and like you do at Peter Mac. But some urologists are very comfortable with the AR pathway inhibitors and all the rest. But, I think we have to give prostate cancer what it deserves. It is a lethal disease, and unfortunately it's become too simplistic. Some people just think ADT, it's simple, I can do it. But, you should not dabble in metastatic prostate cancer. I don't think people dabble in metastatic breast cancer. It would be a crime. Why is it okay to dabble and just treat a metastatic prostate cancer once a month or once every couple of months because you don't see it very often? It's become unacceptable. Prostate cancer has become much more complicated than when I started 30 years ago. And we have to just either get on the bandwagon or work with others that are really comfortable with all that there is to offer. It's unacceptable today to just say, I do a little bit of this and a little bit of that, and I dabble in metastatic prostate cancer once in a while. That's unacceptable today.
And I think one of the things that is changing is the reimbursement situation around the world. And in Australia, pleasingly, we've recently had a positive recommendation by our reimbursement bodies here, so that hopefully apalutamide, one of those fantastic AR pathway inhibitors, will be available, will be fully reimbursed for our patients very soon. We've had the recommendation, which means normally it'll be available within a few months. And that is the first AR pathway inhibitor to be funded in Australia for the metastatic hormone-sensitive setting. So do you think that will change things? What do you think, Renu? Do you think that, if we let, once this is in market and available, if we go out on an education program and really, really inform the front-end users, the urologists and radiation oncologists as well, about this, and then if they want to initiate themselves, great, we can educate people how to use these drugs safely. That's definitely possible. But equally, just feel comfortable referring on to our medical oncology colleagues. But do you think that's going to change the utilization rates for urologists listening to this?
I would hope that it does, because it should. It is the biggest hurdle to overcome. And I think once we overcome that hurdle, then it is a matter of education and support.
So, Fred, we've been talking predominantly about the de novo patient, the person who turns up at the very start with a positive scan. But of course, in heavily screened settings like here in Australia and Canada, patients often have had definitive treatment previously, but relapse. So they're now turning up with a rising PSA and have some metastases. So that is a different population of patients, isn't it? Most of the trials that you've been speaking about on your trip this time are about the newly diagnosed patient. But what about the patient that we very often see, rising PSA, now has disease on some sort of imaging? Do you apply the same high bar of all these patients should have some sort of combination approach?
Absolutely. Yeah. I mean, the data supports that. When you look at the subgroups, whether it was de novo or asynchronous metastases, these patients do just as well. It really depends on volume of disease, just how quickly they're going to become resistant, rather than whether it was de novo or asynchronous. And those asynchronous patients that develop metastases after local therapy do extremely well on AR pathway inhibitors, respond for a long time, because probably most of them have lower burden of disease and really, really do well. And you know, I would venture to say that some of those patients, without using the four-letter word, can actually be cured with very aggressive therapy now that we're doing even metastases-directed therapy in some patients.
And I think that's a really important message because, you know, often when patients present with de novo metastatic disease, it may be that they go to the medical oncologist primarily, but it's a urologist who has treated that patient, who's had local therapy, and then they get systemic recurrence. And that's it. When we're educating urologists, they need to know that it's just as important in that setting to initiate these drugs.
Yeah, well, that's a really important message. So again, a clear message that yes, we should be applying the same principle. But Ciara, these patients are often going to live a very long time. And one of the questions, especially about the AR pathway inhibitor, is how long should we use them for? So whether it's the de novo patient or the recurrent patient, we're going to start some systemic therapy. We're going to start ADT. But, you know, if you've got an AR pathway inhibitor in front of you, how long do we give them for? Is it 1 year? Is it 2 years? Is it forever? Do we know the answer to that question?
Yeah, I mean, I think it's a good question and one that patients ask all the time. I mean, my practice is generally an ongoing administration of that. I mean, in the absence of a compelling reason to stop, for example, toxicity or, you know, these brilliant responses that we do see occasionally, my practice is actually just to continue on.
Yeah. And Fred, before we finish up, two other areas we wanted to visit, Renew. One was about doublet versus triplet. These are new words to us in prostate cancer, but doublet is what we've been mostly talking about. The fact that combining ADT with whether it's docetaxel or an AR pathway inhibitor is like, that's it, standard of care. It should be for metastatic patients. But what's this triplet business? Is it getting more complicated now?
It's getting more complicated because the disease is more complicated. And I think for patients with higher volume of disease that have the higher likelihood of having clones that are truly hormone insensitive from the get-go, the sense is, well, hit them as hard as you can hormonally based therapy with ADT plus an AR pathway inhibitor, plus chemotherapy in patients where there's a likelihood that they have a significant amount of clones that are hormone insensitive from the get-go. And docetaxel appears to be more effective if you hit them early than waiting for them to develop true resistance to your AR pathway inhibitor. So for some patients, triplet therapy, that very aggressive upfront approach, makes biological sense. It's just figuring out who really needs it is still the question. But if you are going to give docetaxel, like you're doing now in Australia, it's no longer the standard of care. ADT plus docetaxel is no longer sufficient because now we've got 2 phase 3 trials that show that adding an AR pathway inhibitor to that doublet makes a huge amount of difference in terms of overall survival.
Yeah, that's it, Ciara, isn't it? So we have Arisens and Piece 1 showing add it all in, but this is a very evolving area. It's not very clear exactly who will benefit, although key opinion leaders can help us select those, but you know, it's so difficult to get doublet utilization. Is anyone really going to be using triplet even in the next 2 years, you think?
Yeah, I mean, my impression is that we will be if we've got the funding, the support by the Pharmaceutical Benefits Scheme to do that. I mean, we shouldn't also forget Enzamet, which is an Australian-led study which also explored the use of a triplet, albeit they required a protocol amendment to permit docetaxel because of the timing of their recruitment. You know, all 3 of these studies that we're discussing, they've all demonstrated improvement in overall survival now. And so I think for that population of patients who are high volume, particularly with asynchronous disease, you know, if we've got the funding, I think we're going to be recommending that to almost all patients we see come through. For the patients with metachronous disease, it's less clear. For the patients with low volume, you know, I think what we're going to be doing is recommending the androgen receptor pathway inhibitor and ADT. The problem with all of these trials, though, is that we haven't actually evaluated what the additive benefit of docetaxel is to these doublet therapies. All three of the studies that we've discussed weren't designed in that fashion, and so that's actually an unanswered question. And I think one that we'd like to extrapolate and feel like we're really intelligent and we've got firm conclusions, but actually the data is not there to support it.
And I think one of the points that came out of the APCCC meeting this year, which is a fantastic meeting, the Advanced Prostate Cancer Consensus Conference, which we posted a few podcasts about, led by Silky Gillis and Aurelius Omlin. It's useful to answer those questions. But
you guys were both there.
Yeah. Yes. And I was very struck by the difference between this year and 2 years ago when asked roughly questions around if you are to choose a combination approach, let's just say a doublet, which should you choose, docetaxel versus this, that, the other. But this year there was a shift from quite a lot of support for docetaxel generally to massive support for it should be AR pathway inhibitors. It was there was a consensus on it, but it was almost make it easy, low volume, high volume, this disease, that disease, this patient, that patient, choose an AR pathway inhibitor. Absolutely. So I think that is an evolving very, very clear message. And then the question becomes, what about adding the docetaxel? I mean, fine, if you have a reimbursement challenge, clearly use docetaxel, but I think taking away those challenges, if you have access, the message is extremely clear now. Yeah. Choose ADT and an AR pathway inhibitor, select the best one for the patient in front of you or you can access, and then maybe the unanswered question about some that might benefit from the upfront docetaxel. Do you think that's a fair message in 2022?
I think you summarized that perfectly. And don't forget the prostate. In low volume disease, don't forget to treat the prostate. And that is us, again, the gatekeepers, to get our radiation oncologists involved. In some countries, surgery is an option, but the data is really with radiation therapy. So in the low volume patient, don't forget the prostate is the source.
Quadruple therapy.
I think we're going to end up with quintuple therapy. Yeah. That's okay if we can start curing this disease.
Yeah. I mean, I think the hardest thing is to break from tradition for many urologists, but I think the key thing is to know the data. Fred, one thing I think we should touch on is, a lot of these key trials, when they reported on radiographic progression-free survival, they were really relying on conventional imaging, CT bone scan. We're now well into the era of PSMA PET for imaging, staging, recurrence. How do you think that changes things, and how do you think that changes patient selection for treatment?
That's a great question, and you guys are to blame for this. I mean, I had
a feeling you might say that.
But we have to embrace. I mean, as much as I've been telling people to be cautious about this novel imaging and how it maybe will change and shift the staging that we've been used to doing, we have to embrace this because it's going to help us not only to better stage and classify our patients, but what I'm really looking forward is to using this novel technology to give us early signals of response to therapy. Because this prostate cancer working group 3 criteria of progression is dismal. I have patients who have died that haven't reached the progression endpoint of 2 extra metastases. And so this new technology really has to be implicated in all of our clinical trials. But for now, the definitions are still based on conventional. Unfortunately, we still have to use conventional for the non-metastatic definition and then for the low and high volume. But clearly, you guys have to lead the way in how we integrate PSMA in our classification of patients.
Yeah, I suppose, building them into trials is the key thing, not always easy everywhere. But Ciara, you're involved in a lot of trials that are using PSMA PET for staging. How do you incorporate data that you hear at these meetings into your practice when in fact the patients in front of you have all had PET scans and haven't had a bone scan?
Yeah, I mean, it's tricky and one we come across frequently. I mean, it would be really nice to think of this in a black and white fashion, but it's just not anymore. I believe at APCCC they didn't actually grapple with this problem as well, and my understanding of the conclusion was that high volume is high volume regardless of how it's diagnosed. So if you upstage with a PSMA PET or demonstrate high volume disease on a PSMA PET, if you haven't done the conventional imaging to start with, that's high volume and you should treat accordingly. It's a tricky problem, and hopefully we'll, with prospective trials going forward, we'll be able to answer it.
I think the only take-home I would make is to not undertreat patients because of PSMA. That is my main concern, that you reclassify a patient and all of a sudden you say, oh, it's too late for local therapy to the prostate, it's too late to surgery. That would be undertreating some patients. If you're going to overtreat, I have less of an issue with that than undertreating patients because of findings.
There we go.
Fantastic. That was enjoyable.
Great discussion, yeah.
Did you learn anything?
Lots. I always learn stuff from Fred Saad.
Oh, it's fantastic. Well, look, I hope our listeners and readers enjoyed that. You know, we were very, very keen to talk about metastatic hormone-sensitive prostate cancer on one of these themed podcasts. The principle of these is these are areas of mutual interest. And, you know, we know a lot of our listeners out there are urologists, radiation oncologists in this field. And we really want to get these messages out about consider why would you start a patient on ADT alone. And yes, I know some of you will listen and say, look, there are some patients. Yes, there are. But let's not get confused. Let's bang out a really clear message that, you know, every single time you're writing a brand new script for ADT or doing an orchidectomy, think, why not? That's Fred Saad's message, I think, isn't it? Fantastic. Yeah. Well, look, thank you very much to both of you. Thank you, Ciara. Thank you, Fred. Thank you for joining us. You're now a friend of the podcast. So I hope you enjoyed
We look forward to seeing photos of you in your hats and beanies. And
yes, so Fred's got some merch. He's going to be wearing it on the flight back to Canada next week. And we look forward to seeing him in person, of course, sometime soon again. So really, that's it for now. We're going to pack up and then go next door and have a fantastic talk from Fred and mix with some colleagues around Melbourne. Should be great.
Can't wait. Should be good.
Thanks very much.